Good afternoon and welcome to today's SAMHSA-sponsored webinar titled CCBHCs Synergies with Crisis Systems, presented on behalf of the National Council for Mental Wellbeing in partnership with the National Association of State Mental Health Program Directors. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments into the chat box, and the questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we will now begin today's presentation.
Okay, thanks everybody for joining us. I'm Joe Parks. I'm Medical Director for the National Council for Mental Wellbeing. And my job is to tee up the topic on synergies with CCBHCs and crisis systems. Our learning objectives today is we want you to better understand how Certified Community Behavioral Health Center model can help you serve people with serious mental illness, particularly those in a crisis situation. We want you to understand the importance of peer support in the CCBHC model, and we want you to understand how the CCBHCs can be the backbone and an essential overall component in your overall community ideal crisis system. I want to remind you, one of our resources here is the Roadmap to the Ideal Crisis System that the National Council published in partnership with the Group for Advancement of Psychiatry. And this is really the intersection of the CCBHC model and how it can fit in that ideal crisis system and support and move it forward. Next slide. So both the roadmap and an upcoming crisis report I'll tell you about are the work of the National Council Medical Director Institute. These are medical directors from National Council member organizations that advise members, staff, board of directors on clinical practices and how clinical issues interact with the policy work and the service work we do. Next slide. We respond to requests from reporters. We do ongoing revisions in mental health first aid, and we provide consultation to the multiple projects and work of the National Council, as well as providing content to the National Council annual meeting at NatCon. And we do ongoing papers. And next, I'm going to tell you about an upcoming paper that's coming out in about the next 2 months. Next slide. This is going to be a report on the role of certified community behavioral health clinics in crisis services and systems. And this webinar is really your early briefing and kind of a teaser to get you to look at the whole report. Next slide. So when we do this kind of work, we get together a broad, representative, diverse group of people that come from all perspectives of the system and all backgrounds in terms of experience and credential. So the information includes the viewpoints of people doing direct care, administrators, policymakers. There's patient and peer input. There's input from researchers on the topic. Payers are at the table because they pay for what we have to have them there to help us pay. State regulators, Behavioral Health Association, and their executives. We want something that builds consensus broadly across the whole field and is seen as useful to the different challenges and constraints that people face, whatever position they play in our very wide and complicated mental health and crisis systems. Next slide. So when you get the report in about a month or two, it's designed as a tool you can customize. It will be lengthy and detailed, but you don't have to go through the whole thing. There'll be an executive summary. There'll be a background piece on Certified Community Behavioral Health Center model in relation to the overall crisis system. You know, there's over 20 certification standards relating to crisis services, and this report will pull them together in one part and explain how they interact with crisis in particular. And that all goes to the level of what do you have to do to meet the minimum requirements of crisis work in CCBHCs, which are extensive. We'll hear later from our other presenters. And then beyond the basic, because we all want to do more than the basic, what can you do to get beyond and offer wider, deeper services, really cool, innovative stuff in different places to new populations. And it's the prospective payment system that makes that possible. We'll explain how you can maximize the use of the PPS to innovate, broaden, and deepen your system. Then there's a section on metrics. How do you measure how well you're doing? And also a lot of examples of what individual agencies have specifically done to get ahead. And finally, for our colleagues in state and federal government with the counties, there's a section on how CCB implementation can support their regional systems and the use they can make of all the abilities and innovation in a community behavioral health system, CCBHC, to support a ideal crisis system across their community. So there's some regulatory detail, there's hypothetical overview, and there's a lot of actual concrete case studies of people that have done it specifically in their area that you all can learn from. Next slide. I'm about to end my part, but before I end, I want to let you know that there are some more resources. There's the Ideal Crisis System Report. We've also done papers on quality measurement in crisis systems, psychiatric leadership in crisis systems, both of which are required in CCBHC standards, require both those quality measurements and psychiatric leadership. There's the Over CCBHC Impact Report from the National Council and another document on crisis response. With that, I want to turn it over to my dear friend and long-term colleague, Carrie Slater-Hodges, previously Commissioner of the Mental Health Department in Oklahoma, and now with the National Association of State Mental Health Program Directors, kind of helping all the rest of those commissioners do it, hopefully as well as Oklahoma did it. Carrie, take her away.
Thank you so much, Dr. Parks. It's always a pleasure, and it's a pleasure to be here with my esteemed co-presenters, and we're so glad that all of you are joining us. And really what I want to talk a little bit about today is, for states in particular, how CCBHCs can really be the conduit to lift, expand, and continued growth and development of their crisis systems. And it is so aligned with doing wonderful crisis work. And I just really want to emphasize that for you. You know, as we know, one of the key components of CCBHCs, whether you're looking at it from overarching from a state perspective or a provider perspective, is really being able to look at what the needs and the gaps and the strengths of an overall system are, so that you can develop a plan to make sure that you're filling those in the best possible way for persons that you serve. And it's also incredibly important to say, as Joe mentioned, that CCBHCs can be a financial catalyst for the development of the crisis continuum of care. And so it is really an important model as we look forward to the continued growth of our systems across the nation. So next slide, please. As we know, crises are something that that's something that happens continually. It could be at 2 in the morning, it could be on a Saturday or Sunday. And so it is incredibly important to have a system in place that can respond whenever needed. And the traditional fee-for-service model does not always support having 24/7 infrastructure when you may not have a constant need for that infrastructure, but the infrastructure is required to be able to meet the needs of the community. And so the development of the PPS model, regardless of which one is chosen, is particularly important for crisis care. And I've heard it likened to a firefighter model, in that if fire departments were paid by how often they put out a fire, they wouldn't be able to exist. And so in some ways, a crisis system is similar, in that the infrastructure must be available 24/7, whether there is a fire or a crisis to respond to or not. And so it is instrumental in developing and continued growth of this nationwide crisis system we're all working on. Next slide, please. And SAMHSA tells us some key things about an ideal crisis system. One is that we need regional or statewide crisis call centers that are coordinating in real time. We need to be able to deploy 24/7 mobile crisis teams throughout the states. We need to have crisis receiving and stabilization programs for people to go for additional support and help when needed. And there are key principles that are built into that model. And that is that we are looking at the recovery needs holistically of each individual, that we know that persons with lived experience can play a life-changing component within these systems, that we also have to be trauma-informed. We need to understand suicide safer care and the pathways involved there. We need to make sure that staff and consumers are safe at all times. And we need to be partnering with other systems within the community, in particular when it comes to crisis with law enforcement. And these are all the things that CCBHC emphasizes as well, which makes it such a great partnership and fit. Next slide, please. One of the things that I think is incredibly important to think about as we talk about crisis is that when you look at the entire continuum of crisis, we want to spend time and effort on preventing crises. Then, of course, we need to manage the situations when a person is in crisis. And then we want to make sure that that person gets to the care and treatment that is specifically best for them to prevent crises in the future. And the wonderful thing about CCBHC is it can really support the work of evidence-based practices throughout the continuum of outpatient care. And I'll give you some examples of how that works. So, for example, programs of assertive community treatment are oftentimes an expensive model to support, yet we have the research to know that for certain populations, it is life-changing. But to be able to have time to have a full team of clinicians, staff, and develop a plan, both crises plans and outpatient plans for an individual, to get their involvement in what their goals and dreams are, and to be able to go out to those persons to provide care where they need it. All of that is a model that requires a lot of support of that infrastructure. And the PPS model does support that. And there are many models like that that otherwise might be more expensive than a state or a provider or a fee-for-service model supports that can be woven through the CCBHC model. Another one of those is the wonderful evidence-based first episode psychosis programs, such as RAISE or Navigate. Those models are fully supported when you implement a CCBHC model. And so these are really key things to preventing people to going into crisis and or to moving people into these care pathways so that they don't find themselves in crisis again. Another one that has been really timely as CCBHCs have emerged across the nation is rapid access for medications for opiate use disorder. And when we talk about the crisis system, one of the things that helps to support and enable is being able to start a person on these types of medications at the earliest point, whether that be at a crisis receiving facility or when someone walks in a crisis, to be able to meet that person where they're at and not say, we're going to give you an appointment 2 weeks from now to start on medication-assisted treatment, but that we can layer that in to what we're doing with the CCBHC model. Next slide, please. Another thing that you hear a lot of conversation about, it's on the forefront of all of our minds, and that is workforce. The growth of the workforce in behavioral health, being able to use a diverse workforce to support the needs of persons in our state. And I know in Oklahoma, CCBHC has been an incredible support for workforce development in a number of ways. One, it allows behavioral health, in my opinion, for the first time, to be able to be on par with other types of industries, in particular with physical healthcare. So, for example, a clinical social worker in the past might choose to work in a physical healthcare setting because the rate of pay to work in that system was much greater than to work in the behavioral health system. But with the CCBHC model, you can pay an individual what the market rate is in your area, regardless of whether a fee-for-service model supported that or not. You can build that into your cost reporting and thus your PPS. So it enables people to pay a competitive rate for persons in the behavioral health workforce and to bring more folks into providing the care and treatment that is so needed. Next slide, please. You know, we've heard a lot of conversation about persons with lived experience and the incredible importance of having them as part of our continuums of care. And I would say nowhere is that more important than in crisis care. And if you think about when a person is experiencing perhaps homelessness or a substance use disorder, or that coupled with mental health symptoms, maybe even having had experience of being involved with law enforcement, there is no one that can show the empathy and tell the story of what it's like to be in that situation, as well as be a beacon that there is life after this particular crisis. And I am here to encourage you and to show you and to model what recovery looks like and that it is possible. And CCBHCs place an emphasis on the utilization of the peer workforce and how important that is in day-to-day work and in particular in crisis work. Next slide, please. One of the things I was most excited about when the CCBHC model was first being discussed and came out was that it encourages the use and the innovative use of technology throughout the behavioral health system. And it supports that. And there's certain types of technology use that are allowable expenses in cost reports to go into PPS. And whether that is to expand the workforce by being able to have persons available for evaluations, et cetera, in the middle of the night, or whether it is to connect law enforcement to clinical support, to help them work with persons that they may come across that may be experiencing symptoms. In Oklahoma, for example, one of the things that we did is every law enforcement officer in the state has a tablet in their vehicle where when they push a button, it connects with the local CCBHC, and they have a person there to help guide them through the situation that has, where they have come across a person that may be experiencing mental health symptoms or may have signs and symptoms of addiction, and helps them navigate what to do next. Sometimes that may be handing the tablet over to that individual to do crisis intervention right there through technology. And if that is not able to diffuse the crisis, then helping that law enforcement person navigate where to go, what the closest means to get face-to-face help for that individual is. Also, technology and the use of dispatching mobile crisis, knowing where mobile crisis teams are, making sure that those loops are closed and that care coordination is happening. And also, what is critical is using technology to help avert crisis in the first place by allowing people to have more access to care and treatment. One of the things that we know across our nation is that oftentimes it can be really challenging to get to care, whether that be having a vehicle that is running or money for gas or someone to watch the children. And so by the expanded use and support of technology, it allows more and more people to reach services and to receive the support that they need, whether that be in crisis or on ongoing care and treatment. Next slide, please. So I want to highlight some of the areas that that CCBHCs have as requirements for crisis care. And I'm highlighting that not only so that you'll know what's been in existence, but also to point out some new criteria that has come into the certification as we all continue to learn and evolve and grow in our crisis work. So SAMHSA recently updated the CCBHC certification criteria to include a stronger focus on helping people in crisis. So one of those is to make sure that CCBHCs are coordinating with the 988 call center serving the area where the CCBHC is located, which is critically important and makes a lot of sense. But now that has become a mandate that everybody will do that who is a certified CCBHC. Also coordinating with local emergency departments, inpatient systems, and law enforcement, whether that be at the time of crisis or to ensure that that person successfully engages in care after and that they know what care is available to them. So warm handoffs in that system are very key. And also to educate people that we are serving about how to plan for a crisis situation, how to access crisis services when needed, and to understand that 988 is always available to them. Also, determining if a person is in crisis at the first contact with the CCBHC, and if necessary, to be able to have a mobile crisis response within 3 hours, available 24 hours a day. And that all of our CCBHCs are participating in their local air traffic control systems. Sometimes you hear that word as care traffic control systems. And that is making sure that we're coordinating with other entities to ensure that when a person touches a crisis system, that we are managing that person's care in the very best way, making sure that they have follow-ups, that ongoing care that is needed is there, and really making sure that we are connected and all a part of making sure people have the very best experience as possible. And that is also a new CCBHC certification. Next slide, please. When we talk about a safe place for help, which is one of the 3 components of a crisis system, we now, as a CCBHC certification requirement, is to provide crisis walking capability for extended hours. That wasn't a requirement in the past, and it is now, as we continue to evolve and know the importance of having these services available, and we will continue to see growth across our nation with these services. To provide care regardless of the ability to pay or place of residence to anyone who needs it. So no need when someone is in crisis to ask questions about their financial situation or their insurance coverage. The key component is to deal with that crisis, to be welcoming, to ensure that the care and treatment that is needed happens at the time that it is needed. Provide a comprehensive set of outpatient mental health and substance use supports, so that either to prevent a crisis or for ongoing care after a crisis. And then one of the things that is so key in the CCBHC model is care coordination. And that may be with primary care, physical health, social services, because what we know is that there are social and environmental factors that play a key role in whether a person finds themselves in crisis or not, or in preventing crises in the future. And so that care coordination is so critical. The initial evaluation and comprehensive assessment must address suicide risks, substance use, and other safety concerns. Develop a crisis plan for every person that they serve. So making sure that everybody understands what should happen in crisis, where they should go, who they should reach out to, the numbers they should call. And to train staff on suicide and overdose prevention and response. This is new as a mandate, but so critically important. And one of the things about the CCBHC model that is so critical on workforce is that it supports and allows, as an allowable cost, the ability to train staff and to ensure that they understand and learn the key objectives here. So to be able to take the time to train all staff on suicide prevention and overdose prevention is a part of the CCBHC model. And lastly, engage in continuous quality improvement so that we are constantly looking at, is what we're doing effective? Are we reaching people who may go through an emergency department and are needing continued help? What about folks that are discharging from hospitals? What about people who we're seeing having multiple crisis episodes? What can we do differently to help ensure that that person is getting the care and treatment they need to prevent future crisis episodes? Really to examine when we do have a suicide death, or attempts, what are the factors involved in that? We really need to make sure that we are looking at that closely to see what we can do to prevent that in the future. And the same for overdoses, both fatal and non-fatal, to understand what we can do differently from a quality improvement standpoint so that we were always improving our system. Next slide. Thank you so much. We're going next to the provider perspective with Dr. Davis.
Thank you so much. That was an excellent overview. I think Joe took us from the galaxy, Carrie took us to the planet, and now I'm doing boots on the ground for the providers. My name is CJ Davis. I'm the Chief Executive Officer of a parent company named Brightly. We are in 5 states, have around 6,000 employees. Just to give you a bit of who we are, our revenue is pushing now 600 million, and 5 states you can see is a small footprint in Oklahoma and Kansas, large in Missouri, some in Illinois, and some in Indiana. So if you wouldn't mind going to the next slide. These are some of the major subsidiaries in our family of organizations that form Brightly. Next slide. So I really appreciate the opportunity the invitation to really offer the provider voice in this. This discussion is so incredibly important, and as door demand increases and access challenges are abundant, a crisis center is a real opportunity. Now, I probably am as keenly aware, and so are you, that crisis centers were probably innovative 3 years ago, 5 years ago. And now they're just sort of the mainstream part of our treatment services. They become a part of our continuum. But I think it's changed a little bit of the landscape of how we all have looked at crisis in general. And it's this notion that centers are no longer looking at crisis as a secondary route into service. And I think that's one of the really important pieces of the crisis service continuum. And it's now become part of the overall storefront, really, of behavioral health care in a really large way, not only for our clients, but in the public as well. It's become a conversation starter about how access is critical and immediate access is critical, and has really spotlighted our mental health needs in our community. I think you would all agree with those things. When we started our very first crisis center in Springfield, Missouri, we were one of the first to market. And it was an interesting process. But what we really decided to push in our communities and realized is that this was a community problem that really required a community solution. We had a very large community mental health assessment about all the needs in our respective area. No surprises. We found that depression and anxiety and substance abuse were three of the diagnostic categories that were most problematic, above the mean in terms of how it compared to other cities that are comparable in size and other states. And so we really realized that then crisis was a key, and the community was asking for crisis. But that was a lot of pressure on us to be able to determine that we were the ones that were going to take on all the crisis needs of the community. I think the next slide talks a little bit about the timeline that actually was associated with our crisis services. So we became a CCBHC in 2017, which was really the jet fuel for everything that we've done and all the growth that we've had over the course of the last 7 years or so. And right around the time that became CCBHC as one of the demonstration states, we also had a community mental health needs assessment completed. Now, the interesting thing about this is it really wasn't pushed by our organization, Borough Behavioral Health, back then. It was actually pushed by a strange bedfellow, which was the county health department. And that was extremely important, that the health department was the convener and the collector of all the data. And what that has certainly then highlighted was that crisis was a real important piece of our particular community. So after the community mental health needs assessment, we identified a site and said, we have a site for this community solution. And then from there, the Department of Mental Health provided us some stand-up funds. And we were also able to have a relationship with the county commissioners that I think was pretty significant, that led to many of the successes with our crisis center. We were able to be a part of a $2 million tax in our particular city, where $2 million were dedicated to a mental health fund. And those $2 million for the first 3 or 4 years of our crisis center were dedicated, half of that, $1 million, was dedicated to the standing up of this crisis center. And so from there, we also visited other crisis centers to try to get some of the best practices that are happening in the country. And we started to sit down with partners in the community that we knew would be extremely important partners. One would be, of course, the sheriff's offices. The other one would be the police department. We're very fortunate and lucky to have the police chief of our particular city on our board. So he was a strong advocate. And then we met with both of our large hospital systems that actually are in our region, multi-billion-dollar health systems, and we utilize their emergency room medical staff to help build inclusion and exclusion criteria. One thing we learned through the process is you didn't want to build a crisis center where people were constantly being denied at the door and the medical community became upset, which would then lead to less referrals. We built 5 more crisis centers, so now we have 6 of the 13, I believe, is in the state of Missouri. And then we just dipped our toes into a brand new opened crisis center, crisis stabilization unit at our new partner in Indianapolis. So now we've become a multi-state crisis stabilization unit system. Next slide. So CCBHC has really made most of this happen. We've been able to utilize our CCBHC funding and PPS rate. Carrie talked about the significance of that. It's extremely important. We've been able to calculate significant cost savings to our counties as a way of investing into these programs. In fact, our health systems, our hospital systems that partner with us invest financially into our crisis centers. And I think without the help of CCBHC, it would be a very, very hard thing to sustain. We've calculated at one particular point in time, it cost about $100,000 to $150,000 per bed or per chair, depending if you have a living room model, more of a residential feel. So they're very expensive, but the influence of CCBHC from the financial stability side has been extremely important, but also really important on the care coordination side and some of the requirements and data that we've tracked over the period of time to ensure that clients aren't just pinged around, but again, how are we really implementing the crisis center into our continuum of care to make a better product and better serve people. So if you go to the next slide. So it's been kind of an interesting thing for us is that we've realized that care really is no longer a transactional point A to point B endeavor for clients. It's actually the very opposite. I think long ago, we've all transitioned away from this expectation. You call a number, you get an intake, you wait a few days, you get a therapist to sign, and voila, you're in treatment. We've really started to use the modeling of the roundabout to help illustrate and visualize for our stakeholders how critical our care continuum is. And now I know people aren't necessarily fans of roundabouts, but let me keep you in the loop on this particular conversation. People can come in crisis or not in crisis, and they're still going to go on this roundabout. They're going to potentially access us through a crisis center, inpatient residential services. They may experience some bridge services as a result of coming out of those levels of care. They may find themselves into community-based services and get back on the roundabout. They even may go into what I call specialty or long-term services and get back on the roundabout. And so we have found that people are able to basically get on the roundabout and off the roundabout in a way that's really important, because this has led to us wrapping more services around our clients, probably more so than we ever have. And it was really facilitated by the crisis center and how best to understand the strategic intentions of implementing this new big service line into our system. I'm going to go to the next slide, please. So sustaining the crisis continuum, of course, there are some things that I believe are critical from a financing perspective, but we have been able to expand our crisis centers, as I previously mentioned, because they are expensive. You become the technical assistance center for the state of Missouri on crisis and crisis centers. But we've really gone all in on our marketing and communication efforts, which I'm going to talk about here in a second, and really wrapped ongoing campaigns to create awareness around our crisis centers and to ensure that people understand, and we are training individuals how to really engage in healthy help-seeking behaviors. And it's been important for our communities too. And I will talk a little bit more about how we've been able to do that here in a minute. But the other thing is to constantly look at the crisis center as just basically best practices now, but then how do we innovate around the crisis center, which I think is the next evolution of crises in terms of centers providing that care in the country. Next slide, please. We realized that we really needed to re-educate the community about crisis and access because in essence, all the storefronts have critically changed. There are no wrong doors, there's more doors, and there's digital doors. And so we wrapped around certain things that we felt like were extremely important for us in an effort to educate the public. We have digital and print advertising. We tie in our crisis center to what we call our Be Well community, which is community education on mindfulness and stress. We have multiple groundbreakings and ribbon cuttings where we invite elected officials, et cetera, to our crisis centers. Plenty of materials for law enforcement. The governor and the mayor and legislative visits have been extremely prominent in the crisis center space in Missouri, and stakeholder presentations. And so I'm a shameless marketer at heart, but I'm a shameless marketer at heart because we really look at it. There are two types of clients. Those are two types of people in our communities. The first type of person in our community is the person that is receiving service. And the second person in our community is the type of person that would consider service. And how do we use this conversation of crisis and mental health, which many people are experiencing, as a conversation piece to advance our cause? So in essence, if you want to go to the next slide. Oops, okay, was that the next slide, I think? Okay, I'll speak of this. Okay. So in essence, what we've really done is we have created a new front door, a new front door. And it used to be one door, but now it's a big front door. And within that door is crisis, which really wasn't the front door for many years. And digital front door is also part of that. We'll go to the slide with the cost savings. I think it was back to, there you go. Through this community education, we really, believe we have impacted awareness and the conversation of community mental health in a way different manner than I think ever before. I think this has been extremely important. And if you can see on the top or on the left side, you can see some of the community savings. Like, how do we determine community savings, and what are some of those dollars that we actually push to the communities? Because we really believe that local government should be a key stakeholders in these projects if they're going to sustain. PPS is a great avenue and reimbursement rate, and the ability for us to look at periods of financial reimbursement and sustainability. But how do you truly create a scenario where the community feels a part of your efforts? Okay, go to the next slide, please. One more. So this gives you a little bit of just 3 of our centers. In terms of the numbers, you can see how they just year over year continue to grow. I want to highlight something that I think is extremely important about this slide. And visiting a center in Indiana really, I think, highlighted this. When we visited the center in Indiana that had a crisis center at Edgewater, we basically learned from them that recidivism actually goes up in a crisis center. And we left that conversation being pretty curious about that. And the theory was, if you're doing your job, you're teaching people to utilize a crisis center. So in effect, more and more people would come back to the crisis center versus only attending for a one unique visit. And you can see that it's actually happened over the course of time in our crisis centers, where you see the orange slowly go up on all of those categories, which are existing clients, which means existing clients are coming back and using the crisis center again. Of course, keeping them out of the operating or out of the operating room, out of the emergency room. Hopefully, there's no operations, but keeping them out of the emergency room, which I think is a really good KPI that should be measured when we talk about data. Next slide, please. The other interesting thing is that what we didn't realize when we opened up a crisis center is that we would be a regional hub for mental health services. And I think this is important because the orange counties demonstrate the number of people, where the people were located in terms of the county residents that became clients in our crisis center. So people were driving really at one particular point in time, almost 1/4 of the state to our crisis center when we were one of the very first crisis centers to open. I'm hopeful now that we have 13 in the state of Missouri has 13, that this map looks a little bit different, but you can see how it becomes a central and core service that a region will use, not just a city, not just a county, but a region potentially could access. I think that's been really important. Next slide. And when you think about this, you can look at some of the data that we've experienced and some of the data that we track. And, a lot of these data pieces and sets are important, community savings, law enforcement wait times, law enforcement engaging, referral sources, et cetera. But we always want to make sure that when people come into the crisis center, that we're connecting them to care in a bigger way. We don't want it to be an isolated, unique service. We want to make sure that that is bridged to other services. So we constantly are tracking who is returning, where are they going, and how we bridge them for care. And from there, what we love to do is to analyze the data and make sure that we're then risk stratifying those individuals that tend to be high utilizers. Not that this is anything that is extremely innovative, but I think it's one of the really important things that we talk about out in the community in terms of how do we constantly get in front of crisis versus waiting for a crisis to occur. This is what we call our slide 11. And it's been a real unexpected benefit of our crisis centers is that it's really allowed us to educate the community about behavioral health care and how it really mimics healthcare's entry points. In fact, we call this slide 11. It was originally on a particular presentation. It was slide 11. We've used it so much, we probably wore it out. But I have found that it's been a beautiful way to have conversations with the particular healthcare groups, with board of directors, with community stakeholders, because we often get criticized for how long it takes to get into service. And we would all agree that 2 weeks, 3 weeks, 4 months, whatever that time period is too long. We've built co-responder units, same-day access, urgent care, crisis centers, outpatient clinics, all to meet the immediate demands, but in many ways, helping to educate the clients and the community about really what we are and how we're compared to healthcare is really an important thing in terms of the education process. First, if you look on the left, you can see that there's 24/7 immediate care, there's daytime walk-ins, there's primary care, and there's specialized care. And if we were just go down the physical healthcare path, we have all those things that we've been very accustomed to receiving as recipients of healthcare. When I have an immediate need, I go to the emergency room. When I have something that doesn't really quite meet the immediate need in the emergency room, and it's during business hours, I go to urgent care. Then I have my scheduled appointments with my doc every year. If I have a cough or a sneeze or a fever, maybe I'll get in quicker. And that's through my primary care doctor. And then there's specialized care. If you want to see a cardiologist, a dermatologist, we have all learned that that just may take longer for us to access services. In the mental health care space, we have a very similar storefront, but we don't necessarily educate the community as much about that storefront. On the 24/7 immediate care, we have our crisis centers. So that's been a really nice evolution. When we have daytime walk-in clinic needs where somebody comes in without appointment, most of us have a connection center or a walk-in center where you can be seen immediately. And if you want to see your primary care version of a provider in behavioral health, that's your outpatient therapist. You probably have developed a relationship with over time, sometimes years. That's your therapist, your counselor, your provider of any sort, licensed individual. But if you need specialty care around psychiatry, autism services, psychological testing, eating disorders, whatever that may be, that's specialty care, and those generally have longer waits. And I think one of the things that the crisis stabilization unit continuum of care has provided us is the ability to really define this for our communities in terms of how do you now access services. And again, all of these services really are on a roundabout or a continuum. So next slide, please. So at the end of the day, we have approached the crisis services opportunity as just that. It's an opportunity. We believe this has been our Super Bowl, our industry's Super Bowl to respond to the immediate needs of our communities. And we've built our crisis services as a part of that continuum in a really profound way. I think the important piece for us that we realized again that it's not a supplemental service, is actually a part of the front door, which has been extremely important. We all believe this, but it's worth it reiterating is that there's no wrong door when somebody needs care, whether that's to the crisis center or somewhere else. But that front door again has been expanded. And that care is no longer transactional from a point A to a point B. It's circular and multidimensional. And I think we've really taken advantage of that in terms of the public education campaign. And then the last thing I think is probably an under-recognized, I've mentioned it once, but an under-recognized byproduct and benefit of crisis services is that we've really been able to educate the community and our clients, especially on health-seeking behaviors and service options. And I think that has really led to a richer experience for our clients with more wraparound care involved. And of course, making sure that above all else, that we're over-serving a community at all times.
Okay, well, I will pop back on camera here. And as I said at the beginning, my name is Matt St. Pierre. I'm a director with the National Council. Thank you all for being here. I want to encourage everybody, if you have questions about anything that's been presented, to please put questions in the chat. I've been monitoring the chat, and we will try to answer as many questions as possible in our Q&A time here. So I want to invite all of our presenters to come back on camera, and then I'll read off some of the questions that we've gotten. So this was a multi-part question from Vanessa. So I'm going to break it down a little bit into parts. But what has been a successful model in a larger, heavily populated county regarding mobile crisis?
I can tell you how we structured mobile crisis in Oklahoma, and so therefore covering our two largest metro areas. One is Oklahoma City and the other is Tulsa, with Oklahoma City having the largest population. And in Oklahoma City, there are 3 CCBHCs. And so when we went to lay out mobile crisis, what we decided to do as a state is to dispatch mobile crisis out of one central location, which is our one state 988 call center. So when a call comes in and that call is screened and determined that a mobile crisis response is needed, then it is dispatched out of 988. And there's a number of reasons why that is helpful statewide, but in particular in an urban model, in that we require, and part of CCBHC criteria is that each of those CCBHCs have mobile crisis teams. And in Oklahoma, they're available 24/7. And that one call center can monitor when the team is out on a call, what their anticipated length of time out on that call is, who's available, who's not available, and then can utilize that information to decide who to dispatch next. So they have the ability to manage those teams from a perspective of who's closest, who's not busy, et cetera, to expand their ability to respond as much as possible. Now, in addition to that, there is something else that we did in Oklahoma. So each CCBHC has mobile crisis teams, but we also have another overlaying vendor that provides mobile crisis as well, so that as we implemented mobile crisis statewide 24/7, we could keep track of utilization and understand where more teams need to be, and had some flexibility to change that as needed. So, for example, in the Oklahoma City area, when we first started and our CCBHCs had mobile crisis, then when we saw that there was certain times of the day or certain areas that needed more capacity, we could layer additional capacity in that metro location. So then we didn't have 3 teams that we were had the ability to dispatch. We had 5 teams that we had the ability to dispatch. And we could also look at when that we were most likely to need all teams to be able to respond, and what times of the day when perhaps we didn't need all 5 teams available and on call. So that's kind of one way that we look to do it in a large metro area, by having the CCBHCs with their teams, having one overall dispatch and monitoring of those teams, and then having an additional layer that we could layer in additional teams anywhere statewide that we saw that capacity needed to be built up in those areas. And some of those were surprising. Some were not urban areas that had a greater need for additional teams, but also urban areas were the same. Dr. Davis, did you have anything to add on how you do urban mobile crisis?
I think you covered it. I think for us, the big key here is to establish as many micro clinics as you can around a city. So, the important part is, how do you bridge them to aftercare and stay connected to them? But I think I agree with everything you said.
Yeah, I think, Carrie, you managed to answer most pieces of that multi-tiered question with your one answer. But the one piece that kind of, I think, we didn't quite touch on is, when you have, like you said, in Oklahoma City, you had 3 CCBHCs that were all serving that. Vanessa's question is, she's in a county with 4. So do they each run their own separate mobile crisis, or do they share resources given the workforce challenges?
And so, yes, based upon capacity needs, they each have mobile crisis teams, but they are dispatched out of one central location so that we're able to manage those resources in the best possible way. And the CCBHC can have additional mobile crisis teams that maybe they utilize for internal calls, or that aren't a crisis going through the more overarching continuum. So say they are serving a person that happens to call them up, and they determine that, it'd probably be a good idea for us to send someone out. They can make that determination as well.
The St. Louis metro area has done the same for their large metropolitan region. They have a shared call center dispatching that they all contract through, and that connects people to all the various crisis services, mobile crisis and crisis stabilization and next day appointments that allows them to flex. If somebody's busy, somebody else picks up the slack. But they do trust each other and share enough to share the disposition and triaging of the services.
Yeah, I think one of the things that Dr. Parks mentioned that is key is really that trust and collaboration as opposed to competition. It really, when it comes to a crisis continuum and it comes to trying to have the best utilization of resources, that collaboration and trust between entities is really key.
Awesome. Next one, this is more of a comment from Anne. She's experienced buy-in issues with the CCBHC model in rural locations, and then she invites the panel to come to her state to talk to her state to try to change that.
I would
go ahead, Jerry. You first. You're the more rural person than I.
Well, I would say in Oklahoma, we have a lot of rural areas. And in fact, one of the things I did early in my career was work for a community mental health center that covered 8 counties in rural Oklahoma. We had a crisis unit, and really we were pretty responsible for the population in those 8 counties. And I think it really is, this is where needs assessment and building those collaborations around the community is so important. When you really are starting to talk about the kind of change you can see and what kinds of things can be brought to fill the needs in a community, you can really help to get people on board with that. But I do understand it's a process sometimes in really bringing folks on board and helping them understand the importance of what this model can bring.
I do want to add something just about rural communities because it is a unique challenge, and just a couple of things that as I listened to that question, I was just sort of thinking like, what were some of the lessons learned? So when we first started, when we created our very first crisis center, we had 16 chairs, and we thought they would be full the entire time and people would stay there 23 hours. What we found is they were hardly full because people were staying there 4 to 6 hours. And so the throughput was way quicker than we anticipated. And I thought that was really an interesting finding because we probably built our first one too big, and it's only a 4,000 square foot building. But then what we started to do is to pare those down and maybe have 3 or 4 or 5 chairs, which is not a ton of cost, but still have the hard part, of course, is the cost of this to the staff. And so I think we've seen the model actually become pared down. But then there was a third piece of this that we've never been able to execute. And I think it's a great idea, but we just haven't been able to do it yet, is to look at a crisis center as a bit of a hub and spoke. And most places in the country have some sort of access hospital, critical access hospital. I mean, literally, if you had a room with a chair in a rural area that was maybe tied to a hospital or some location, you could do virtual hub into another crisis center. There's no reason why virtual services couldn't help de-escalate people, stabilize them, give them assessment. If there was a nurse or some equivalent with boots on the ground, the small rural one-person show crisis center. So I throw that out there only as an idea because I think that would be something that would be very unique and could become executed upon if there were the right partners in place to make it happen in a rural area.
I'm not quite sure what barriers specific to rural areas the questioner's experiencing. Some that we do see is in rural areas, there's often some smaller providers. It can be difficult for an organization to meet all the requirements of CCBHC by itself, or there may be other important small organizations that are not going to make CCBHC criteria. And understandably, they get concerned, will they get a fair shake in the deal? How do I fit in this new arrangement? The mechanism there is through being a designated contract organization, a DCO, But doing that requires a fair amount of mutual trust, willingness to take risks together, which is challenging for any set of leadership teams. And it also requires a fair amount of business skill and something that many groups of providers would do well to bring in some technical assistance to make it clear to the leadership of the organizations that want to work together what the advantages and what the complications are. But the technical complexity is not the big thing. It's how much can you trust each other? How much are you willing to take risks together? And how willing are you to be vulnerable with each other? If you do that, I don't think there's anything stopping a rural area that has some key essential smaller providers from fully utilizing this model and getting a lot of value out of it. But it's going to take that stretch on leadership part.
I think those are such great points, Joe. Sometimes in a rural community, it takes grouping together providers to really be able to meet all the essential components. But the great thing about CCBHC is in reality, that's an option. So great points.
So then we had a question coming from Alexis. This is a great question, actually. How does the PPS model support ongoing education and training and skill enhancement for new and current persons working within the crisis system?
Oh yeah, all that can be, whatever amount of training you want to do can be included as a administrative infrastructure cost in your cost report. And the cost of that training gets spread across any PPS billing you do. The CCBHCs that have done really well have not just done individual training, they've also done practice coaching of particular practice locations. And it is an opportunity to do as much training as you have bandwidth for, because it is a very legitimate cost in your cost report.
Yeah, I think what Dr. Parks is saying is so key, is that in a traditional fee-for-service, which most all of us have operated under for years, there really is not a reimbursement mechanism to be able to keep your staff trained up on the very latest and to teach them about care pathways, evidence-based practices. But with CCBHCs, those really are allowable expenses that can go in that cost report. And so then the PPS, so the payment received per person served, contains coverage for those costs of keeping your staff trained up, being able to provide clinical support for them, and really be able to build that workforce that you've always dreamed of in terms of expertise and knowledge.
Okay, next question is from Darren. Can you speak a bit on the impact on peer services that CCBHCs have had for the communities, and how do you measure quantifiable change?
Well, you know, there is a lot of papers and research out there around the use of peers and the improvements in engagement in care and persons completing care versus dropping out of care. But I would also say where I have seen it particularly have an influence is in the crisis continuum. When you have a receiving facility that you are being welcomed by someone that has lived experience and starts to talk right from the get-go about, I have been right where you're at. I have been in a crisis. I've been in a crisis receiving facility. I know that this can be really scary and we're going to walk this walk together. It makes such a huge impression with individuals in terms of lowering their anxiety and fear about what's going to happen, but also to know that this is someone that has been right where they're at. So there is data and research out there. I don't have it at my fingertips to share with you, but I have certainly seen it firsthand. And the ability that someone with lived experience has to decrease anxiety and to have that empathy and relatability to someone that is experiencing those symptoms and crisis.
So I think the advantage, the usefulness of CCBHC for peer services is that they can either, they again can be carried as a cost. You don't have to get any particular billing unit. Peers struggle to get specific billing units for all the different stuff we want to use them for. I think that the major obstacle in many ways of measuring the impact of peers is not having any kind of standard definition of what it is to be a peer. In some states, it takes a lot less training and experience than in other states. You can't, it's very hard to make direct comparisons because of the huge availability. And this is an area that peers need to come together and work on, is standardizing what they see, what standards you have to meet to get this title as it becomes more and more essential and professional. I think the other problem I have with the question almost of measuring the impact of one type of the interdisciplinary team member, we wouldn't go saying, well, can we show what the difference the therapists make? Can we show what difference the psychiatrists make? Our model is an interdisciplinary team model, and we shouldn't go picking apart to prove that one person is more valuable than another. I think appropriately, CCBHCs are focused more on measuring the impact and changes of the model as a whole. I think the question you ask is a good one, but I think it's more a research question than an agency operation question.
Yeah, and you know,
I
it
may
also
not agree. That may have been a spicy answer for some of my co-respondents.
we're used to your spicy answers, Dr. Parks. Thoughtful answers, thought-provoking. The other thing I would say I think that CCBHC does have an impact on is in most fee-for-service systems, the payment model is based upon the cost of the salary of someone. So oftentimes in states, you'll see peer interaction with staff being reimbursed at really low rates. And so that often has the effect of people not wanting to lend itself to the use of persons with lived experience. The nice thing about CCBHC is it doesn't matter who within the team is providing care and support and treatment. That PPS can be triggered by what is an allowable triggering service. And so this model allows the use of peers to be much more blend itself to the use of peers in a much better way. And instead of pulling back maybe because the reimbursement is low, it allows you to lean in and where appropriate to be able to blend and mold that into all the types of care that are being provided.
Okay, we have another question that I'm going to try and broaden a little bit, but there are some states where a CCBHC cannot DCO with another CCBHC. Any ideas how two organizations can create a BCC that covers the same area if we can't DCO with one another? How can two CCBHCs come together to help when the state's kind of saying you can't formally DCO together?
I've not heard that happening. I think it'd be possible if you found two centers that are very, as Joe mentioned earlier, trusting of each other. I think the more complicated side of it would be is how you divide those costs across the board on the PPS rate in terms of your cost report. You'd have to have a pretty strong finance team to do it, but it wouldn't be impossible. I think those kinds of collaborations and alliances could certainly occur, especially in those areas where it's heavily populated and multiple CCBHCs exist. I think what you'll find is that the hardest part of all of it outside the PPS is to determine where the steerage occurs and where that client is from, and then who does the follow-up services afterwards so the client doesn't get in the middle of the two entities trying to fight for a particular client in their outpatient care or community-based care. And I think tracking the entry point into the system and the exit point would be extremely important, but I definitely think it could happen, but it'd be complicated.
Oh, please go ahead, Joe.
So it's hard to answer not knowing why the particular state thinks this is a good idea for them, because it's hard to think of an alternative without knowing the problem we have to take care of from the state side that led them to take this position. I imagine they might be concerned that the CCBHC with the lower PPS would rather get paid a higher rate than their actual PPS by the CCBHC with a higher PPS, that they have some kind of economic gaming concern. If that's it, there's ways to get around, and I don't think I can answer the question without knowing what problem the state has that leads them to take the position. Would welcome an outreach as a sidebar to think through it with the particular parties that are having this obstacle. Have not heard it before. Kind of fascinated now.
And I was thinking that perhaps it's not a DCO with a financial arrangement that's needed, that maybe it's more of a really good business affiliate agreement where there's not necessarily a reimbursement mechanism there, but just making sure that everybody knows what to do in what situations and what needs to happen when I'm providing care here or not. Although I do know that there is going to be further guidance coming out on non-financial DCOs in the future, and that may help clarify some questions around that. But I would agree, Joe, it probably has to do with concerns about multiple billing, different PPSs, when someone's a CCBHC member of one organization, and how does that get changed in the system, and all those types of things.
Well, Stacy, you fascinated Dr. Parks. So as he said, please feel free to send an email to follow up on that specific question as well, to dive more into those concerns. Next question, does the CCBHC structure support working with outside peer specialist groups who collaborate with your org and provide 24/7 recovery support, but are not on staff? So I might broaden that question a bit to like working, does CCBHC structure support working with specialist groups who collaborate but aren't on staff?
I'm not sure I followed that. Hit me again with that.
Oh, you mean outsourcing their peer group since they can't hire their own, essentially?
Yeah, I think that's what they're saying. Yeah, like how do you help bolster your workforce with peer supports or other services that are not on staff? Does the CCBHC model help support that?
Yeah, you could do a DCO arrangement, and you can pay them in 15-minute increments. You can pay them a flat daily rate, and it goes on the CCBHC cost report. The method of payment between the contracted entity and the CCBHC has to pass the sniff test for being reasonable, but it can be whatever methodology is mutually agreeable between the groups. Now, at that point, though, the CCBHC, it is as if they were providing the services, and they are responsible for making sure that contracted group does everything consistent with CCBHC certification standards. So it would be best that the outside group really understand they may be asked to do some stuff they haven't been doing, or the CCBHC will have to figure out a way to get that stuff done. It takes a little bit of sitting down and going through the details.
And I believe that is a model that's utilized in some different locations around the state, where you have some peer organizations that are longstanding and have done work and do have DCOs with CCBHCs to do a lot of that lift on the peer side for them. And I do think it's something that can work well when done right.
I don't think there's any difference between DCOing out a peer versus a psychiatrist. So I think there's a model in place and a precedence to do that. And when I look at our client satisfaction scores from individuals that go through the various crisis centers, from a thematic interpretation perspective, it clearly, the peer is extremely important to that person's experience, not that the rest of the team isn't. So I don't know if it really matters where that person's employed or how they are present, as long as they are following the agency's policy and they can transition between a culture that's expected in one entity versus a different culture that they're providing care. So I could see it as something that would be very viable.
Then we had a question from, okay, go ahead, Joe.
No, Genevieve's question is cool. Can CCBHCers join in peer trainings that are not funded by the CCBHC? Any CCBHC TRAF can participate in any training that's not funded by the CCBHC, and the CCBHC should say thank you. Now, the converse is the CCBHC can fund the training, but I'm all for CCBHCs getting free training from other people.
And then we had a question from Josh. So crisis stabilization centers, when they're standalone, can have large budgets, considerable staffing, and can serve lots of people. Is there information anywhere on what the budget average staffing models are for crisis stabilization when done within CCBHCs? And is there any restriction on how big those services can be when done on the CCBHC side?
Well, the only restriction is that they can't be residential, so they can't be treating people past 24 hours. You know, they can cover your first 23 hours, and when you go past that, when you're in a bed at midnight instead of in a chair or a waiting area, then you're residential, and that can't be in the CCBHC cost report, and it'll have to be some other payment methodology covering that. But there's no upper limit to number of beds. And there's actually not a hard defined staffing mix that you have to have. You could do it with relatively low credentialed staff, and you could do it with all PhDs if you wanted to do such a silly thing.
And I do think there is, well, one of the things that we see across the nation is there's huge variability from state to state in how they define, say, an urgent recovery center or a crisis stabilization facility. There is work being done on trying to get some standardized definitions when we use these terms across states so that maybe we can understand a little bit better. But right now, those terms can mean all kinds of things in all kinds of places. Some may be have a nurse and a physician component where they're prescribing medications and starting MOUDs. Some may be more of a peer run kind of component where they're providing support and care. So I think if you've seen the cost of one, you've probably seen the cost of one because of the variability in models across the nation.
And then we had another question just pop in from Jennifer. Not quite sure, but what about mobile crisis being dispatched by 911? I think the question is, can mobile crisis be dispatched by 911 as well as 988?
So I will say one of the things that is such a pleasure in the work that I do is that I get to see so many different models across the country. And there are different models around the country that are dispatched out of 911. And there's also lots of different ways that 988 and 911 connect across the country. One model that I have seen is that there is a co-responder model that clicks in when 911 is called. So you'll have a mental health professional then that's working in conjunction with the law enforcement if the call came through 911. And then separately, if the call comes through from 988, it would be more of a traditional mobile crisis without a law enforcement intervention. But then there are states that have really good connectivity behind the scenes where 911 is talking to 988 to say, this is the situation. Will you determine whether law enforcement response is needed or whether your mobile crisis will manage this? So there's a lot of different models out there. And I think over time, we'll continue to get research and outcomes from the different models. But what I've seen right now is either connectivity behind the scenes to make a determination on who should respond, or a model that if the call comes into 911, there's a co-responder model that goes out.
We just started this in Springfield, Missouri with one of our subsidiaries, and actually we're having our 988 and our 911 and our crisis team all in the same building together. So they're actually collaborating around the call before there's even a deployment of whoever. And we're finding that, anywhere between 20 and 30% of the calls in a 911 actually probably should be more of a 988 call. And so you're actually having the two dispatch teams, in a sense, work hand in hand. And there are calls coming in right now at the 911 center that our mobile crisis are being deployed to because we know of the client, we know of the situation, and law enforcement is not going. So I think Carrie's correct. There's a lot of different things that are happening. I would call that integration of those systems at sort of the base versus trying to figure out it higher up on the tree where it becomes more problematic and costly.
Okay, and then I had a question for Dr. Davis and a question for Dr. Parks. So CJ, it's interesting that roundabout, the way that that's conceptualized, we tend to see it more as like a continuum. Wondering kind of if you can talk more about what led your organization to kind of conceptualize it as more of that roundabout.
I don't know if it was one pinnacle moment, but what I believe is that we could have the same conversation around how care is being evolutionized right now. When somebody comes into services and they request outpatient, it's no longer even the matter of outpatient. It's what kind of programming and pathway they can fall into. Like, let me give you an example. Somebody comes into our service line, they may be more appropriate for group psychotherapy. And group psychotherapy data is now suggesting that has about as a critical component on care and outcomes as individual psychotherapy for some populations. And so we think about that, the long line we have, if we can funnel somebody into a group, or we can funnel somebody into some web-based trainings. There's fantastic startups out there that you actually are viewing videos of therapy, and somebody viewing videos of therapy can have an impact on their particular symptoms. Again, new research forming, but interesting. And then you have some people that can be educated through web-based learning. And so, or somebody that comes in and you should benefit from 3 to 6 sessions. And so we've trained all of our therapists on brief solution-focused, solution-oriented therapy models. And so even the front door of what we all would have considered as outpatient therapy is changing. So it seems like what we're doing is back in the old days, we had a very poorly constructed 2-lane highway from city A to city B. And what's happening before our eyes is that we are creating super highways all around us and off ramps and roundabouts. And some of those are very, very well manicured and look pretty. And some of those are just gravel roads that we're just starting to sort of go down that path and want to pave. But I think that's where we are all trying to look at is the kind of the intersection of technology and care and understanding that it's not this transactional sort of thing. And what we found at the crisis center is that we would have somebody come into a crisis service and they would go back out to another part of our organization and then come back to crisis center and then go out to another part of the organization they weren't accessing. And it became this web. And we just sort of realized over the course of time is that that's what happens in healthcare too. But it's now happening before us in behavioral healthcare. And now how do we take that to the next step and educate people that, hey, this is acceptable. And maybe 10 years from now or 5 years from now, it's not only acceptable, it's just the standard practice of onboarding and serving people.
Wonderful. Thank you. And Dr. Parks, one question for you. Back at your portion of the presentation, you talked about the fact that the upcoming CCBHC crisis publication is customizable. Can you talk a little bit about the rationale behind making that resource customizable?
I want to first say kudos to CJ for tailoring the service to what the person is willing to accept as opposed to what we thought we needed to do with your brief solution-oriented therapy. For decades, the customer, the people we're serving, have just wanted a couple of therapy visits. So as Medicaid director, the total number of visits of therapy I paid for everybody in Medicaid was 1. And you've had the vision to design the therapy in terms of what they expect instead of saying, oh, too bad, they're dropping out. Well, they got what they wanted and they're gone. So kudos, good job. Matt, reframe me the question again. I just got excited by CJ's answer. That's all.
The tool, the upcoming CCBHC crisis tool, it's customizable. You made mention that like you can use it to customize things for yourself. Can you talk about the rationale of having a tool like that be customizable?
Absolutely. So CCBHC is such a versatile, broad spectrum of services of what it must do, but in terms of what it can do, there's a whole lot more. And even in terms of what you must do, there's various ways to do it and different preferences for sequencing it. And any good management I've seen, you take advantage of the right moments and the momentum you have. So I may emphasize different things than CJ's agency just because of my local environment, of what's easy to move forward for, or what he may have a bigger pain point in one place than I have a bigger pain point. It's easier to get people to change if you're doing it in response to something that they see as currently distressing than to convince them they have a problem where they don't think they have a problem. That's what I mean by customizable. You want all these components over time, but how much you want how soon is a local opportunity. And why not do it when you have an easy opportunity and people are interested, as opposed to forcing something where they're not yet interested or don't yet feel distressed that they feel need to be relieved. I think all organizations want discretion on how they do things, and this offers that discretion. It's different in different places.
Wonderful, awesome. Any final thoughts, Carrie, before we close out?
Oh, I would just, I would say the paper that has been put together that will be coming out in the next month or two really does a great job of summarizing a lot of the things that we talked about today, and really how incredibly important CCBHC is in providing great care, and in particular, crisis care across the nation.
Awesome. Well, thank you everyone for your participation. To our panelists and everyone, I'm going to toss it over to Bailey to close us out.
Thank you. And thank you to our presenters for a wonderful presentation. This does conclude today's session. You may now disconnect.